Hello everyone. Today we are going to discuss about the gestational diabetes mellitus. So let's go with the topic. So I have approached a new method of learning so that I'll be uh, saying the things by remembering, and I have highlighted the point to remember. So maybe it will be helpful for you to also learn. So give me feedback in the comments. Let's start with the video. So for the definition, like GDM is defined as a carbohydrate intolerance of variable severity. So uh, carbohydrate intolerance of variable severity with onset or recognition during pregnancy. So it is the definition. So for the risk factor, like previous history of uh, gestational diabetes mellitus or the carbohydrate intolerance, and then the first degree parents have the carbohydrate intolerance diseases and polycystic ovarian syndromes, and obese women, and the age more than 35 are elderly women who are having the pregnancy. So these are the risk factor for having the gestational diabetes mellitus. So which time like this gestational diabetes mellitus will be occurring is like mainly in 24 to 28 weeks. Why? Because in that time human placental lactogen hormone will be higher, along with estrogen, progesterone, and the cortisol also contribute to the gestational diabetes mellitus. So it has insulin lytic action, and it increases the resistance of the receptor of the insulin. So uh, it has the two action, and it can causes gestational diabetes mellitus. So we have to check uh, the blood sugar level by different method at the appropriate time, which is 24 to 28 weeks. So for the screening and the diagnostic test, so there are high risks, moderate risks, and the low risks. So for the high risks, like history of gestational diabetes, first degree parent have diabetes mellitus, history of macrosomia baby born, and the history of glycosuria. If then these along with this, like previous history of the stillbirth child, this can be also high risk. So if the high risk patient visit to the OPD, at the first visit you have to do the OGTT, but for the other risks, then we have to uh, first do the GCT, which is glucose challenge test, and then if the value is rearranged like not normal in this, like it crossed the threshold, then we have to do the OGTT. So mainly it is done in the 24 to 28 weeks already told. So what is the principle of these tests? Like for the GCT, irrespective of the fasting, we do not have to be fasting, and then 50 grams of the glucose is administered with a 1 glass of water, and then after the 1 hour the blood glucose level is measured. Then if the value is greater than 140, then we have to do the OGTT. There can be different value, like we can also take greater than 130. If we take the 140, the sensitivity is 80%, which means that 80% of the future GDM cases will be covered if we take the 140. And if we take the cutoff of 130, then it is 90% sensitive, as uh, it will cover the 90% cases of the GDM in the future. So the cutoff value will be vary within the institute. So then if the value is greater than the threshold value, then we have to do the OGTT. For the OGTT, the principle is like we have to do the fasting, and then 75 gram of the glucose is taken with a glass of water. Then before that we have to take off fasting blood, and then after taking this, then we have to take after 1 hour blood sugar level, and after 2 hour the cutoff value is 92 180 and 153. So if one of the value is deranged, 1 or greater than 1 value is deranged, then we can diagnose it as gestational diabetes mellitus. There are many institute which is giving its value, like there are NDDG, National Diabetes Data Group, and Carpenter and Coston. These have also given the data of the values. So main which is follow is this GCT and the OGTT, which you have to know. So this is important, and the cutoff value is 140. So what to do after the diagnosis, as GDM is already diagnosed to the patient? So we have to do the diet modification and exercise. For the diet, like less than 40% of the carbohydrate, less than 40% of the fat, which is like less than 10% of the saturated fat, and other fat can and other thing like 20%, and we have to take the 3 meal system, like 25%, 30%, and 30% of the meal, and other percentage we have to take the small food interval at a time, which is morning, day, and at the night. So this type of the dietary modification can be done. And for the exercise, we have to do the exercise for a week, 5 day a week, and in a day like 30 minutes of brisk exercise, brisk walking can be done as a exercise modification. So after the 2 weeks we have to 2 weeks we have to call the patient for the follow-up, and then we have to do the sugar profile. So in the sugar profile, we have to do the fasting blood sugar, and then 1 hour after the meal, and one pre dinner and post dinner, 4 value are taken. So for the cutoff, like 95, 140, 100, and then 140. It is in the pattern protocol. So these are the things we have to consider in the sugar profile. So for the, if the value is deranged, then we have to use a medication. Best choice of the medication in the patient which is pregnant is insulin, as it cannot cross the placenta. So insulin is best choice, and short acting and long acting insulin are added, and then we have to give insulin therapy. If the patient cannot or do not want to take the insulin, then glyburide drug is also can be used, and metformin. These drugs are not used in the first trimester, but in the second and third trimester we can use the metformin also. So for the time of delivery, so if the patient is under the control of the diet and the exercise, then we have to 39 to 40 plus 6, we have to do the delivery at this time. And if the patient is under the control of the insulin therapy, then 38 to 39 plus 6 weeks. And if the patient have vascular diseases, then we have to do the 37 to 38 weeks. Around this week early we have to do the delivery of the baby. So what are the complications that can occur in the patient? Like during pregnancy, there can be preterm labor, premature rupture of the membrane, and then polyhydramnios, big baby formation, diabetes ketoacidosis, diabetes nephropathy, diabetes retinopathy. This type of complication can be occurring during pregnancy. During labor, like prolonged labor, shoulder dystocia, as there will be the macrosomia baby, and then there can be like difficult in labor, so shoulder dystocia. And the perineal tear, as big baby come from the vagina, then there is chance of perineal tear. And during puerperium, like lactation failure, puerperal sepsis, and lactation failure, puerperal sepsis, this thing can be occurring in the puerperium, like subinvolution of the uterus or other organ can be occurring in the time of the puerperium. So like fetal complication, first at the fetus there will be the hyperglycemia. We have to understand this, so that the baby, there will be more lipogenesis, and then there will be accumulation fat all over the body, and the baby become big, macrosomia greater than 4 kg, and like congenital abnormality can be occurring. Mainly congenital abnormality are mainly seen in the overt diabetes. For the like diagnosis of the overt diabetes, as in the fasting, as if the fasting is greater or equal to 126, and after the 1 hour, if it is greater or equal to 200, and in the random blood sugar level, if it is greater than 200 with symptom, then we can diagnose it as over diabetes. So what is over diabetes is that the diabetes which is occurring before the pregnancy, like already there is diabetic in the mother, so it is called as over diabetes. So mainly in the over diabetes there is more chance of congenital malformation, because there will be the hyperglycemia around the first trimester, so that their organogenesis can be halted and the congenital malformation can be occurring. But also in the GDM also there is a chance of congenital abnormality. Like most common congenital abnormality is in the cardiac system, and the most common is BST, but most specific is like transposition of great vessels, and the most specific feature or congenital abnormality which is seen is sacral agenesis, which is best which you have to remember, sacral agenesis. So these congenital abnormality can be seen in the fetus. So in the neonate, as in the fetus, there is hyperglycemia, and in the neonate there will be the hypoglycemia. So you have to know this, why there will be the hypoglycemia in the neonate, as like this is the mother, and then the placenta and the baby. So in the mother there will be the more glucose coming from the mother to the baby. Then like as already talked, like insulin cannot cross the placental barrier, so glucose can only goes to the baby. So baby have to produce the insulin on its own, so there will be the beta cell hyperplasia in the baby's cell. So as there will be the insulin resistance in the mother, so more glucose will be going to the fetus, so more hyperglycemic is seen in the fetus. But when the baby is born, then the supply of glucose is stopped, so that the insulin which is due to the beta cell hyperplasia, there will be, so there is more insulin, so that the remaining glucose is sent to inside the cell by the insulin, so that there will be the less glucose in the blood, so there will be the hypoglycemia in the neonate. So we have to check the blood sugar level after 1 to 2 hours after the born of the baby, which mother is suffering from the gestational diabetes mellitus. So other conditions are like polycythemia. So why polycythemia is that, as we know that the glycosylated hemoglobin can carry less amount of oxygen in the RBC, as and also in the placenta, like the placental cell, if the placenta carry like more like glucose, then the surrounding cell take more glucose from the placenta, then it will be swollen up, so that less blood can pass to the baby, so that baby have to as a feedback mechanism, baby have to secrete or release more RBC. So more RBC will be occurring in the neonate, so polycythemia can be occurring. And as there is polycythemia, as there can be also hyperbilirubinemia. As there is polycythemia, more RBC, and more RBC will be degraded, so more bilirubin can be formed, so hyperbilirubinemia can be seen. And hypomagnesemia, hypopotassium, and this thing, okay, like magnesium and calcium also, less calcium, potassium, and the magnesium is seen in the neonates. So these are the things you must know in the gestational diabetes mellitus. So if anything left, I'll be covering in the next video. And how was the video? I'll give feedback in the comment. Thank you for watching video. Keep watching Dr SpiNy video. Bye.